Hello everyone, good evening, and now we are going live on YouTube, and by sharp 7:30 we will begin the session.
Hi, Dr. Ajit. How are you? You got unmute. You're muted.
Okay. Hi, how are you?
Fine, sir. So where's your friend, Kalur?
I got just a call from him. Within a few minutes, he will join.
Okay. What about your president? Not president, secretary. What's his name?
Actually, secretary is not in selection. I think he's in travel.
Oh, he's traveling, is it?
Yeah.
Okay. Our Shaiju?
Shaiju, okay, he will join anyway.
Okay, Shaiju, Vishnu Nambudiri.
Everyone will join anyway.
Okay.
Yes.
So you're going to do the welcome speech, right?
Yeah, today I will.
Hello, good evening, Shibanji.
Good evening, good evening. How are you?
Yeah, I'm good, sir.
Nice.
I'll introduce Dr. Ajit. He's our Secretary of Hyderabad Medical Association, State Secretary of Hyderabad Medical Association.
Yes, I see that. I see. Hello, Dr. Ajit. How are you?
I'm fine. How are you, sir?
Doing very well. Thank you. Thank you for coming here.
Okay.
Whether Damle sir has not joined?
Yeah, he's here. DD.
Yeah.
Yeah, Manoj, I'm there.
Yes, sir.
I'm just reading few things, so I don't want you to see me reading.
Okay.
Your protocol, print out.
Yeah, I've not received it. I was waiting for that.
No. I have to just read, and finally, I have few corrections. I will make it and send it.
Okay. And there's Dr. Dr. Ajit. Ajit is our State Secretary.
Oh yeah, I saw him. I spoke to him.
Okay.
Where is Rija Chechi?
Yeah, she is there. I think we can send today night itself.
As soon as this is over, I will have one round of talk with Bharat. Send it across to you.
Okay.
Bharat.
Class
I think today people are a little slow. We may have to wait for 5 more minutes. Otherwise, or should we start the initial process?
Okay. So we'll start at 7.
No, I think introduction, welcome, and all that anyway will take 10 minutes, right?
Hardly 5. Yeah.
Okay, we'll start at 7:35. Is there any Sadat is not coming today, is it?
No. Dr. Ajit is here. He will.
Yeah. What about our Shaiju?
welcome. Shaiju is in some. He is in duty in. He's having duty in FLDC or something. So he is not getting the line. It seems he just called me. Some
Okay.
range problem.
Vishnu Nambudiri?
Actually, Vishnu Nambudiri, I call him. I'll just see whether
Call
he's
him now.
there.
I talked to him in the afternoon from RCGB, and
I'll ask him to join.
yeah, we told him that we'll sponsor his study. He wanted to do study on dengue and chikungunya.
Yeah. He told me about that. I told him that we'll discuss.
Sir, shall we start?
No, wait till another 5 minutes. No?
Okay, sir.
Bharat, you are not letting viewers to come here. You are showing them on YouTube, is it?
Yes, sir. Yeah.
Okay. I was just wondering.
Audience can.
Joining.
Yeah,
Okay.
yeah. Audience can watch in YouTube, sir. No.
Okay. In that case, let's start. Okay.
Okay.
Bharat, start.
Yes, sir. Yeah, good evening, everyone. This is lecture series 3. Dr. Shiban Ganju, an expert, is with us to talk about viral hepatitis. And we are all really excited to listen to Dr. Shiban Ganju. And I request Dr. Ajit Kumar, the Secretary of AMI, to welcome the panel members and audience. Over to you, sir.
Hello, good evening, everyone. On behalf of Ayurveda Medical Association of India, ATRIMED and AVVBS, I extend a warm welcome to all the participants to our lecture series, An Hour with an Expert. We had already completed 5 wonderful lecture series in this series. Today, we have a most important topic, viral hepatitis. As we know, Ayurveda done wonders in this area. I find immense pleasure to welcome Mr. Shiban Ganju, founder and chairman at Remed Pharma. He is a gastroenterologist and he is a wonderful personality. I think he is the right person for presenting this topic. I also welcome our other distinguished panelists, Dr. Rishikesh Damle, CEO at Remed, Dr. Manoj Kadu, and my friend AVBVS, Dr. Leda Damle, and I also expect Mr. Shaiju Alakod, my friend Dr. Shaiju Alakod. Once again, I welcome everyone to this session and I request your kind participations. Okay, thank you.
Thank you very much for your wonderful welcome speech, sir. And it's really right time to listen about Dr. Shiban Ganju, who is an expert of this hour. I request Dr. Rishikesh Damle, CEO at Remed Pharma, to introduce our expert of the day. Over to
Thank you,
sir.
Bharat. It is my pleasure to welcome Dr. Shiban, whom I have known for past 25 years. Dr. Shiban graduated with MBBS from All India Institute of Medical Science. Then he did his post-graduation in medicine from AIIMS. Later, he joined Indian Army. He served Indian Army for a few years. Then he went to US and he certified from Board of physicians and gastroenterology. He was practicing in US for till last year, and he was a consultant at Chicago Ignalls Hospital. He was also associated with Chicago University for some time. Dr. Shiban is a very charming personality. Dr. Shiban has got done a lot of work for India apart from doing in healthcare. He founded a NGO called Save Mother Foundation, which works in rural areas even now, and achieved something which was very difficult to achieve. That's bringing down the infant mortality and maternal mortality in rural villages. He is also founder of Atramed Pharmaceuticals, and he is the guiding principle behind the scene all the time in past 18 years. He has published several papers. He writes articles. He has given a lot of speeches. He's invited quite often to conferences to give insights on healthcare. So if I have a lot to talk about him, but then to cut it short and start the function, I would say just go to atramed.com website and you can see his complete CV. You'll be really impressed to see whether one man can do so many things in his life. Over to you, Dr. Shiban.
Thank you, Dr. Damle. Thank you, Dr. Ajit. The topic today is viral hepatitis and update. And I'm going to share some slides with you. Are we doing it right, Bharat?
Yes, sir.
Can you see the screen?
Sir, go to the slideshow menu at the top.
I do. I did.
At the top, sir. At the top. You have a menu bar at the top. Yeah,
Yes.
please.
Okay. Okay.
Yeah.
Got it. Okay.
Yeah, sir. It's now much better. Thank you.
Okay. All right. The topic today is viral hepatitis. We have various kinds of hepatitis. I've just mentioned a few here. These are the viruses that cause hepatitis. When we say hepatitis, normally we mean viral hepatitis. It could be drug-induced hepatitis and other hepatitis too. But generally, the inflammation of the liver, the commonest causes are viruses. They're named A, B, C, D, E. We up to E now. And then there's cytomegalovirus, Epstein-Barr virus, herpes simplex virus, and many other viruses. Almost all viruses cause some minor inflammation of the liver. Today we'll talk about hepatitis A, hepatitis B and C mainly, and I will also allude to A, C, D, and E. B and C comprise the maximum disease burden in that they become chronic, and the world over they cause quite a bit of havoc. Hepatitis probably is the commonest disease in the world. Just hepatitis B and C, we have 25.7 crore of hepatitis B people living in 2015. This is the data from World Health Organization 217, a report of 2017, and the data is in 2015. So hepatitis B, 25.7 crores, and hepatitis C, you add 7.1 crores. So that brings it up to almost 32, 33 crores right there. And if you add A, D, and E, so it'll be close to 40 crore people have hepatitis in a year. And B and C progress into cirrhosis and carcinoma, and there are hundreds of thousands of deaths from these diseases. The sad part is only a minuscule people who are chronic hepatitis are under treatment. The data shows just 16.7%. And the children all over the world infected, 1% of the children population infected. Now coming to India, close to 4% people have hepatitis in India. And the 4 crores carriers, which means the chronic infection people of HBV, hepatitis B, and 1.2 crore hepatitis C, that comes to 5.2 crores right there. And if you add other viruses, close to 6 crore people have it. And the sad part is in tribal population, prevalence is almost 4 times higher than the normal population, 11.85%. Here's the hepatitis B structure, and the man who discovered is a fellow called Baruch Blumberg. His pictures above. His birthday is 28th July, which is celebrated as the World Hepatitis Day. In the 60s and 70s, we didn't know what caused hepatitis, so we used to call it serum hepatitis. The two prevalent terminologies at that time were serum hepatitis and infectious hepatitis. Serum was blood-borne, and infectious was given through GI tract, oral or food was giving the rise to the hepatitis A. Baruch Blumberg was working in Australia, the tribals, aborigines of Australia, and he was looking the genetic polymorphism there. He found that if you mixed the blood of tribals of Australia with people of people who had some mental disorders, there was some reaction. He didn't know what it was, so he called that Australia antigen. So whatever particle he found, or he guessed there was something in the blood of the tribals of Australia, so he named it Australia antigen. It's later, when he was working the Down syndrome patient who had got hepatitis, about a hepatitis, who was previously negative for Australia antigen, He tested him again and found he was positive for Australia antigen. So he linked this hepatitis with Australia antigen. And then his lab technician fell sick, who again had Australia antigen negative before. She got sick with hepatitis and became Australia antigen positive. So he formed a connection that Australia antigen was a virus. He continued working on it for many years, defined the virus, and found the genome, and he got the Nobel Prize in 1976 for this. His collaborator was Dr. Atler, who worked with him, and he continued to work on various viruses afterwards. Now, the structure as we know it now is this is the so-called Australia antigen or hepatitis B virus. It has an outer lipid envelope like many viruses there are, and it has a core inside, shown in here, the diagram in orange color. The total particle size is about 42 nanometers, and the core is about 27 nanometers. And the core contains a double-strand DNA. The double-strand DNA is kind of unusual here because one strand of the DNA is complete genome, and the one is only about 50% complete. So it's only half the genome there. And there's a DNA polymerase attached to the 5' end of the DNA. It produces a few proteins. This virus produces a few proteins. The main ones are the HBEG, hepatitis B E antigen, and then hepatitis B core antigen, HBCAG, which is related to the core, and HBsAg, which is HB surface antigen, which you normally test in the blood. It so happens this virus produces more surface antigen and E antigen than the virus particles. So these S antigen and E antigen particles float in the blood, even if they are not in part of the virus there. The virus enters to hepatocyte. This is a kind of a diagram of hepatocyte. And it enters like many viruses do. The endocytosis attaches to a receptor, in this case called the NTCP, sodium taurocholate polypeptide receptor. Right on the top, you can see the virus entering. There's another mechanism of fusion with the hepatocyte membrane, which is not well understood. So this endosomal, the virus entry by endocytosis within this endosome, the virus sheds its outer covering and the inner capsid remains. It's shown in green and red color here. The red is the coating here in the virus, which goes away. And the capsid, which is in green color shown here, which remains. This capsid then enters the nucleus of the cell. This is transported through microtubules, enters through nuclear pore complex into the virus. Now, the genome from the capsid is released in the virus in the nucleus of the hepatocyte. Now, this is interesting because remember, half the genome, half the DNA is only incomplete, and only one strand is complete. So it has to go through a repair process that the incomplete strand is completed, and then it forms what is called the cccDNA, which is covalent closed circle DNA formation happens within the nucleus. The closed circle covalent DNA unfolds and the transcription happens and the RNA is formed, messenger RNA is formed. Messenger RNA leaves the nucleus and becomes the template for building new capsids. Proteins are added to it and new capsids are formed. Now this capsid transports back into the nucleus and stays in the nucleus and replicates. So you see this very unusual thing. The capsid proliferation happens within the nucleus and capsid stays there, and this double-stranded DNA can stay there as this triple C DNA as a microchromosome. It stays inside the nucleus forever. That's why it's difficult, almost why impossible to eradicate hepatitis B completely, because it stays there and there's a reserve of capsids which are produced and stay in the nucleus. Now, this capsid can also get to the endoplasmic reticulum, from where it's transported and secreted out of the cell to infect the other hepatocytes. So what you have then in the bloodstream is the hepatitis B virus, and mind you, surface antigen and E antigen, which is produced for each virus. There is almost 10 to 100 times more surface antigen produced. The surface antigen comes in small, medium, and large sizes. Smallest is the commonest size. What you measure generally in blood test is this small antigen. The incubation of once you're infected, it's a very efficient virus. Only 100 viruses are needed to infect a person, just 100. So incubation is up to 6 weeks, and the incubation period, generally there are no symptoms. And the patient may be positive, did the blood test, may be positive for hepatitis B surface antigen and E antigen. Once the symptoms start, the acute phase may last up to 3 months, which is characterized by malaise, fever, muscle aches, jaundice, high-colored urine, clay-colored stools. Bilirubin in the blood is high, ALT, AST are high, and hepatitis B surface and E antigens are positive in the blood. After 3 months, 90% of the people get better. They go to convalescence phase, where surface antigen disappears and the immune reaction of the person creates antibodies. The first one to appear is hepatitis B core antibody. Remember the core of the core antigen? Well, the antibody to that is core antibody, and hepatitis B surface antibody. And hepatitis B E antibody also becomes positive. If hepatitis B surface antigen persists for more than 6 months, and 9% people, 5 to 9% people carry this more than 6 months, this is called by definition chronic hepatitis. So chronic hepatitis is persistence of hepatitis B surface antigen for more than 6 months. Remember I said hepatitis B surface antigen, there's plenty available, and E antigen plenty available without the virus inside the nucleus. So there's plenty of material still available to infect the other hepatocytes. So progression to chronic hepatitis, 5% adults become chronic. And during perinatal infection, it can be transmitted from mother to the child. And 80 to 90% of people or children who get infection during birth, they become chronic hepatitis, 80 to 90% of them. And if children get infected below the age of 6, about 30 to 50% becomes chronic. So you see the burden of disease is so huge, and it's up to us doctors to detect them and treat them. If the hepatitis persists, it leads to cirrhosis and cancer. 20 to 30% people with chronic hepatitis become cirrhotic or get cancer. Here's a graph of what happens to antigens. The vertical axis shows the titer of various antibodies. The horizontal axis gives you the timeline. It goes up to 8 months. So the green curve is the hepatitis B surface antigen. It becomes positive even in incubation period, even though person is asymptomatic, and persists for 4 to 5 months. If it persists more than 6 months, it becomes chronic, shown in a green curve here. And then the next thing to appear in the blood is hepatitis B core antibody. Hepatitis B core antibody starts in 6 to 8 weeks and stays positive for a few months, which shows in the blood, it shows a recent infection. Hepatitis B E antigen also appears at the same time and then disappears if the patient recovers. Hepatitis B surface antibody appears a few weeks to few months later and persists depending if the patient recovers, then disappears in 6 months. If it doesn't recover, it becomes chronic. What happens to the hepatitis B? 90% of the patients recover. Less than 1% people die because of fulminant hepatic failure. Fulminant hepatic failure happens normally because of a co-infection with hepatitis D or a delta antigen. We'll come to that later. That somehow or the other causes fulminant hepatic failure and people die. And the remaining, which is 5 to 9% people, become chronic. Patients with acute infection are E antigen positive. E antigen signifies active infection, active proliferation of E antigen in the nucleus. But if the person survives, then they become E antigen negative. 60 to 80% people become HBe antigen negative. That means the liver is recovering, and this is called HBAG loss. At which time the DNA, HB DNA, decreases to less than 2,000 units, and liver inflammation decreases. Of those that are infected at childbirth, 6 to 10% remain HBe positive even after 40 years of age. They become chronic infection there. Here's another graph which shows in a diagram how it progresses. In the top, you see acute hepatitis B. It can be acquired during perinatal period, childhood, or adult. During perinatal period, the child becomes immune tolerant. In other words, immunity of the child does not respond to the virus. It seems S antigen and E antigen may be responsible for cover up and make the virus go under the radar. So the child or the infant doesn't realize that the liver is infected. So they become immune tolerant or show no immunity or show no immune reaction. So the virus survives a long time. In a childhood disease, which is under 6 years, they can become immune active as do adults. The body reacts to it, and when you become immune active, that means there is active inflammation in the liver, and you can become chronically infected, or you can resolve the infection. Most of the adult infections become inactive and get resolved, close to 90% of that. But then they can be reactivated and become again immunologically active. So this cycle goes on and on. Most of the people recover, like I said, up to 9% become chronic, and half of them will develop cirrhosis and cancer. The tragic part is the perinatal infections, which is totally avoidable. A sizable number of them are sick for the rest of their lives. This shows you what it looks like in chronic hepatitis B. They're classified as immune tolerant phase, immune reactive phase, inactive phase, and reactivation. Now, immune tolerant, like I said, happens in childbirth. In this phase, if you got a patient who's immune tolerant, the blood test will show that hepatitis B surface antigen is positive, E antigen is positive, hepatitis E antibody is negative, ALT is normal, DNA levels more than 20,000, which means active inflammation, active replication, the virus still happening in the nucleus. but histology is normal. Patient child is asymptomatic. There is no treatment needed. This immune tolerant phase may last for 30, 40 years, and after 40 years, it can become active again, become immune reactive phase in adult age, which is the second column. If you have a patient, you encounter a patient immune reactive phase, you will see surface antigen is positive, E antigen is positive, E antibody can be negative or positive, ALT is elevated, DNA is again very high, more than 20,000. Histology shows necrosis, inflammation. There's a chronic hepatitis there, and patient is symptomatic and they need treatment. Otherwise, they'll become cirrhotic or develop cancer. So in this immune reactive phase, they become rapidly turn from immune tolerant, which is a quiet phase, to immune reactive and leads to serious inflammation and serious liver disease. Now, if you acquire this infection in adulthood, you can have surface antigen is positive, E antigen will be negative in the beginning, anti-E will be positive. That means the person is reacting to the antigen and therefore immunity will get better of the virus and the person will recover. ALT in this inactive phase is normal. DNA level is less than 2000. Now, DNA level is generally measured, and less than 2000 is considered quiet, and for this, no treatment is needed. If you did a liver biopsy, show mild inflammation, patient is asymptomatic, and there's no treatment needed. Now, in this 30% people of this category will reactivate. If you remember the last graph, they reactivate and go to the last phase, which is reactivation. And the reactivation phase, again, you have a active inflammation in the liver. Virus is replicating in the nucleus. The virus is producing surface antigen, E antigen, and damaging the liver. So therefore, your surface antigen is positive. Patient may have anti-HBe positive, AST, ALT, and elevated, and DNA is high this time because activity is rampant in the nucleus. And liver biopsy, which show necrosis, fibrosis, patient is symptomatic and treatment is needed, and disease damage to the liver happens fast, goes into cirrhosis or even cancer. This is another graph showing progress of hepatitis C. At each stage, how do you evaluate? See, the problem is that since we cannot cure hepatitis B, mind you, hepatitis B virus as a triple C capsid is in the nucleus forever. It's like a microchromosome which lives in the nucleus of the hepatocyte. And hepatocytes have long half-life, and it can last there for months to years inside there. When the hepatocytes replicate through mitosis, there's asymmetrical distribution of the virus into the daughter hepatocytes. So both the hepatocytes may not get equal amount, but then the hepatocyte, which is already loaded with capsids, DNA, E antigen, is infecting other liver cells, and gradually inflammation changes to fibrosis, which changes to cancer. So the whole sole purpose of treating hepatitis B is control the fibrosis and hopefully prevent the cancer. And we have various markers. Some of them are old that you're aware of, and some of them new. I'll go through them. If you look at the bottom square and the timeline early, when you monitor chronic hepatitis B, CHB is chronic hepatitis B, we monitor them by checking hepatitis B surface antigen, which we normally do in the blood. So we know person has prominent hepatitis surface antigen persistent for more than 6 months in the blood. So by definition, it's chronic. Now we want to know whether it's active or not. So we check hepatitis DNA. If it is more than 2,000 units, we know there's activity happening. That means virus is proliferating in the liver cell. So it's a serious condition now. So there's a new antigen that's come into, it's not available at the moment, but it will be the hepatitis B core-related antigen, hepatitis B CRAG. Now, CRAG can be positive even when E antigen or DNA is low. It can be positive, it can be detectable, which tells you chronic inflammation is happening even though your DNA and E antigen are not showing anything. Similarly, this MAC2 binding protein glycosylation isomer also becomes positive. This is at the moment experiment, it's not in great use, but HBCRAG will be available in pretty soon. This chronic hepatitis then progresses to fibrosis. Now you want to know whether this fibrosis is happening or not. There are non-invasive ways that is done routinely nowadays to see whether this fibrosis is happening. Because you want to be proactive with the fibrosis happening, then you really want to treat these people. Fibrosis can be detected in when it's large amounts and by ultrasound, main ultrasound, or MRI or a CT scan. But if it is not as much, then you want to do what is called transient elastography, which is like an ultrasound probe, and you measure the surface of the shear wave passing through the liver, and the fibrous tissue, the speed of this increases, and this is called transient elastography, which tells you how much fibrous tissue is in there. Or you can do FibroSure score, FIB score, which is age, AST, ALT formula is available. You plug in those numbers into the formula, there's you a FIB4 score, and basically when the score worsens, you know the fibrosis is getting worse. Or one of the simplest one is APRI, which is AST to platelet ratio index. You measure the AST and measure the AST platelet ratio, and that will tell you whether these are progressive fibrosis diseases happening or not. Of course, you can do ultrasound, CT, and MRI to see the fibrosis. The fibrosis, half the people, maybe 30 to 50%, will become cancerous. Now, AFP, which is alpha fetoprotein, is not detectable in early cancer, and early cancer may not show up even on ultrasound. So there are blood markers which are used, at least AFP-L3, which is this lens agglutinin reactive fraction of the AFP, which may become positive. And there are other measures, experimental ones, called protein-induced vitamin K absence factor and DICOF-1 factor, which can be measured. These are experimental at the moment. So that tells you whether the person has cancer or not. The important thing is if you catch cancer early, then by either lobectomy of the liver or liver transplant is curative. Once the cancer becomes big, more than 5 centimeters, and there are multiple multicentric cancer, then there's no hope except for some chemotherapy. So that's why early detection is very important. A liver transplant or a lobectomy is curative. You can cure the patient completely. Which comes to our treatment. Now, this all exercise was diagnosing hepatitis B, people who become chronic, we had to follow them, and then at what point do we treat and to what purpose? Now, the purpose is to get into what is called a functional cure. That is, we treat the person so there's no hepatitis B surface antigen or DNA detectable in the blood. We call it functional cure. Mind you, you cannot kill the virus in this person. The virus is ensconced in the nucleus of the hepatocyte. I'm belaboring this point again and again. it is there, undetectable, and is ready to pounce or ready to replicate, ready to reactivate. And there's plenty of capsids available in any hepatocyte and a lot of surface antigen, E antigen, which make the person immune and evasive towards the virus. That some kind of protection is attained because of S and E antigen. So this virological cure is unattainable at the moment. So the best we can hope is a functional cure. That is, you treat the person, surface antigen disappears, DNA disappears, or you can have a partial cure. That means your DNA is less than 2,000 even after the treatment is stopped. So if you see, the goal is to reduce liver failure and hepatocellular carcinoma, and the response to the treatment is judged by DNA and HBsAg, and of course doing the ultrasound, CT scan, and the other blood tests that I mentioned in the previous slide. Now, when do you treat a person? You can't treat them all because maybe they're immune inactive. You don't need to treat them. So you treat them by these markers. These are indicators. So one is during immune active phase, when the activity is rampant and person is actively inflamed, which is indicated by DNA, HBsAg, and HBe antigen. There's evidence of moderate liver inflammation and fibrosis in case there's a liver biopsy. And you treat such kind of people that the DNA is more than 2,000 and there's evidence of inflammation, AST/ALT is elevated, and the person is post an active phase, surface antigen is positive, we start treating them. There are conditions when DNA is 20,000 or more. So it doesn't matter whether AST/ALT are elevated. It doesn't matter whether surface antigen is positive. DNA more than 20,000 means virus is actively replicating. You treat them. Similarly, patient with cirrhosis, irrespective of what the blood tests show, had to be treated. So when you have cirrhosis based on either ultrasound or the other blood test, FibroSure or FibroScore or APRI test, AST, platelet ratio index, if there's cirrhosis, you treat them irrespective what the AST DNA levels are. So to summarize it, if DNA level is more than 20,000, a patient has cirrhosis, you treat them. If the patient has evidence of fibrosis, is in an active phase, that is DNA is more than 2,000, HBsAg is positive and E antigen is positive, you treat them. If they're inactive, you don't treat them. If they're immune tolerant, you don't treat them. Now, what do we have? We treated these people with pegintron or peg interferon. And peg interferon is not a really good drug because it's got side effects of fatigue, mood disturbance, cytopenia, and anorexia, quite a bit of weight loss. And so they come out with some antivirals. Entecavir was is a drug now, but the current favorite is tenofovir alfenamide or TAF. Resistance is low at 25 milligram daily, and response is pretty good. So this is at the moment the drug of choice. The second best is TDF, tenofovir disoproxil fumarate, TDF, 300 milligrams daily. The side effects are lactic acidosis, but they are rare. Nephropathy is rare. We do not use the drugs that we used just a few years ago. Lamivudine, adefovir, they're not preferred because lamivudine resistance was very high. Whenever we treated people with lamivudine, they develop resistance pretty fast. And adefovir can cause pancreatitis and renal damage. So the current choice would be tenofovir if it is available. Now remember, Harvey Adler was a collaborator of Baruch Blumberg. When Baruch Blumberg got Nobel Prize in '76, Harvey Adler was working still with him, or maybe separately at that time. He's got a 50-year career in this virology, hepatology. So at that time, 1 in 3 people develop hepatitis after a blood transfusion. 33% people who got blood transfusion developed hepatitis. Once Australia antigen or hepatitis B virus were discovered, and we started screening blood before transfusion, the transfusion hepatitis we thought will disappear, but it did not. It decreased by about 80%, but we still have 20% people who still got hepatitis in spite of screening the blood for hepatitis B. So there was some other infective agent suspicion was there's another virus that's causing this hepatitis. Now, we didn't know what it was called at that time, so it used to be called non-A, non-B hepatitis. We knew it was not a B hepatitis because Australia surface antigen was negative. We knew it was not hepatitis A because of history, which is orophycal route. I'll come to that in a minute. So by history, we knew it was not A, and A antibody was negative. So you had A antibody negative, B antibody negative. So what was it? It's called non-A, non-B hepatitis. We didn't know what it was. Patient used to come with mild elevation of AST, ALT, and normally in our practice, we used to say, you'll get better, don't worry about it. Except Harvey Adler kept working at it, and he found it was a virus because when he transfused the blood of these non-A, non-B hepatitis people into chimpanzees or chimpanzee liver, they got hepatitis. So he knew it was a virus causing it, except he didn't know what the virus was. So came this is next scientist, Michael Houghton. Michael Houghton was working with the Chiron lab, Chiron Pharmaceuticals. And the problem was we knew it was a hepatitis virus, but nobody could see it. Nobody tested, nobody could find it. So they tried and tried and tried, couldn't find it. So Michael Houghton and his collaborators did a very clever trick. They went the proteomics way. What they did was took the nucleic acids, isolated nucleic acids from the infected patient, and created proteins through bacteria to these nucleic acids. And these proteins then, the hope would react with a person who's got hepatitis C. Hopefully he'll have antibodies. And they went on and on and on and on. And finally, one day, after many years, they found a reactive material after millions of tests. They found a reactive material, a reactive protein material, which reacted with person with hepatitis C. So they knew it was a virus, so they named it hepatitis C at that time. Except the tragedy was they still could not replicate it. Nobody could replicate it. So came Charles Rice into the picture. So we have this non-A, non-B hepatitis, presumably hepatitis C. We have a proof that it can infect people. We have an antigen-antibody reaction shown by Dr. Michael Houghton, except nobody's seen the virus. So my Charles Rice looks at it and says, all right, probably there's something wrong with the genome itself. And he discovered there are 100 nucleotides missing from the genome that people had described before that. So I added those 100 sequences there and then tried it. And guess what? It didn't do anything. So it wasn't a complete virus. So he did another clever thing. They created what is called the consensus genome. So each nucleotide, they planted the most probable nucleotide and created an old consensus genome between those scientists. And lo and behold, now they could replicate it. So the hepatitis C was born. And all three of them got Nobel Prize this year. So hepatitis B, Bruce Bloomberg got earlier. Harvey Adler, who worked with him, that time was left out, but he continued working for 50 years. And this year, all these three scientists, really clever work, got Nobel Prize for discovering hepatitis C. Now, this is the structure of hepatitis C. It's an RNA virus. Mind you, hepatitis B was DNA virus. It's a single strand genome, and it has an envelope which has two glycoproteins, E1 and E2. It has a capsid. Inside the capsid, there's this single strand genome. Now the HCV RNA, the RNA can code for 10 proteins here. There are structural proteins, 3 of them, which is capsid protein E1 and E2, and there are non-structural proteins named NS1, 2, 3, etc. And these are the proteins that this RNA virus produces. It's a positive sense single-stranded RNA. It is larger than the B virus, which is 47 nanometers. This is about 55 to 65 nanometers. Like I mentioned, it produces 10 different kind of proteins. Now, this is important. It comes in therapy. That's why I'm sort of belaboring the point. Non-structural proteins. This is how you attack it to cure it. And now it's a pretty active virus. A virus produces 10 raised to the power 12 viral particles daily. Now, this enormous replication rate definitely induces mistakes in the genome from one generation to another. And because of this enormous variation, so when you see the patient's blood, it is not one species, they're quasi-species. There are multiple mildly changed forms of same virus. It may not be a different virus, but none may not be a different genotype, but within the genotype, a subspecies or a quasi-species. So there's a cloud of viruses going through. Now you understand why these people had difficulty in isolating the virus, making the virus, because not one virus, and replicating the virus, because the genome is so variable. And therefore, virus, Charles Rice, the third man in the troop, had to make his own genome, which was the most likely the original virus. Now, there's 6 genotypes. Now, this is pertinent to our treatment. 6 genotypes, they're numbered from 1 to 6. Now, genotype 1 is common in South India, and genotype 3 is common in North, East, and West India. Genotype 3 forms the 60% of the virus, known viruses, and 1 is 30%. Rest is genotype 4 is 4%. So it's important because the treatment, the antiviral treatment, depends on what genome you have. So if you have a patient with suspect hepatitis C, you do hepatitis C antibody, then you do the quantitative RNA, see how much the viral load is there, and then you find the genotype. This patient is ready for treatment then. A virus entry is as usual. The viruses enter, attach the receptor, just like in B virus is endocytosis. And now this virus stays in the cytoplasm, does not get into the nucleus. So there's it sheds its coat and starts producing RNAs. So there are 10 proteins are made, and the RNA replicates and then reassembles, acquires a coat again, and the virus is released. So again, a virus enters the hepatocyte and goes through the cycle of replication and is released out to infect other liver cells. So hepatitis C, there's an acute infection. Most of the people are asymptomatic. Symptomatic is so rare that I, in almost 4 decades of doing this hepatology, I never seen an active C infection. You always catch them as asymptomatic chronic. Typically, a patient comes with a blood test which shows mildly elevated AST and ALT in the range of 40 being upper normal, less than twice the normal. It's about 60, 70, at the most 100, not more than that. And non-specific, no symptoms, and the patient comes to you normally for something else, and you just happen to look at the blood test and show AST, ALT elevation. So once you see such a patient, it's incumbent upon doctors to test for hepatitis C antibody. If that is positive, then you check for RNA quantitative and genomic testing and start, if this positive, treat the person. Now, 50% of these people, whether they're asymptomatic or symptomatic, become chronic. That's the sad part of hepatitis C. Hepatitis B, only about 30% become, 9% became chronic. Here, half the people who have hepatitis C infection, mostly asymptomatic, become chronic and develop cirrhosis and cancer. So close to 25% of liver cancer of the world is because of hepatitis C, and almost equal number, about 27% of the cirrhosis of patients because of hepatitis C. So hepatitis C in the beginning is pretty unoffensive virus, doesn't damage you much, but gradually it simmers and damages the liver. And 20, 30 years later, lo and behold, you got cirrhosis and you got cancer. So this is the slide that shows what I said earlier, another graph, another cartoon that we saw earlier. The liver picks up the liver hepatocyte, picks up the virus, endocytosis, the fusion happens, and then it sheds the envelope, the capsid is translated, replicated, and released. But this slide is important, shows these 4 squares, 4 rectangles that are in light yellow color, which shows where all we can attack the virus in treatment. You can remember I mentioned the viral proteins. So you can inhibit those nucleosides. You can NS3 inhibitors. You have NS5 receptors, 5A and 5B receptors. They are inhibitors, which is antiviral drugs. Now it's important because hepatitis C is curable. 95 to 100% cure rate of hepatitis C. So it's important to treat this virus, important to diagnose it and therefore treat it. And one of the most satisfying things you ever would do is treat hepatitis C and cure. Mind you, within my lifetime, what I used to call in my practice as non-A, non-B, didn't know what it was. Then they found it and we said, all right, it's hepatitis C, but we didn't have the drugs. We should treat with people with these drugs, PEG interferon and ribavirin, and I've treated many people for many years. It was a miserable thing because ribavirin would cause hemolytic anemia. So 9 or 10 hemoglobin was normal because there was nothing else available. You hung in there. If the hemoglobin dropped till 8, then you stopped the treatment. Similarly, PEG interferon would cause enormous side effects. The main were serious one were these life-threatening neuropsychiatric disorders. They get suicidal, depressed, or even homicidal. I've had 2 patients. One was homicidal, other was suicidal. I had to stop the treatment. And myalgia, fever, arthralgia was very common. We didn't have any drugs. We continued with this till we got these drugs. These are directly acting antiviral and that change the whole scenario. I'll go to the number 3 from the top. Sofosbuvir. This is a miracle drug, almost no side effects. It cures all genotypes 1 to 6. The only difference is type 3 genotype may take longer therapy. Normal therapy is 8 to 12 weeks. This may take a little longer. And it inhibits, it's a nucleoside inhibitor. It inhibits NS5B polymerase, which is a key enzyme for RNA replication. It's extremely well tolerated. And better still is if you mix sofosbuvir with other drugs, which is given in the last 3 lines there, ledipasvir and velpatasvir, and now new combination, 3-some there, velpatasvir and voxipravir. But sofosbuvir by itself changed the whole outlook. Sofosbuvir with one more ledipasvir or velpatasvir cures 95 to 100% patients. So we should, as doctors, never miss a chronic hepatitis C because they can be cured. If you remember, once upon a time, we used to say it's a viral disease, we don't have any drugs, antibiotics don't work. Here, lo and behold, we have these drugs now that can cure a viral disease and prevent cirrhosis and cancer. Now I'll come to hepatitis A, D, and E. Now hepatitis A, D, and E do not cause chronic hepatitis, and they're self-limiting, and therefore we'll see a lot of them, but they're not of chronic consequence, and that's why I kept them to last, and we just go through them quickly. All these hepatitis viruses are RNA viruses except hepatitis B, which is a DNA virus. So A, D, and E all RNA viruses. The A and E viruses are orophycal route. They're self-limiting, and vaccination against hepatitis A is effective. Vaccination is available. Hepatitis E, again, is orophycal route. It's interesting, the virus was discovered in Afghanistan. In retrospect, they found in the stored blood that the 1955 outbreak of hepatitis in Delhi was because of hepatitis E. Once the virus was discovered, they rechecked the blood and found it was hepatitis E. So hepatitis E happens sporadic episodes. A few thousand people get it. I just mentioned 2 in the slide, Delhi and Kanpur, where 50 to 100,000 people got infected at that time. This reservoir is in pigs. So mind you, it's a zoonotic virus then, so it can come from pigs. And again, local hygiene is extremely important. Hepatitis E is lethal in late pregnancy. In 3rd trimester pregnancy, if you get hepatitis E, 20% mortality. Otherwise, this is a self-limiting disease like hepatitis A. Now, hepatitis D is interesting. It's a very small virus. It produces only one protein, which is called delta antigen. It cannot replicate by itself, and it uses hepatitis B to replicate. So if you treat hepatitis B, you cannot get hepatitis D. So immunization against hepatitis B protects you against hepatitis D. Now, once you get B and D together, you get fulminant hepatic failure and death, hepatic coma and death. So any person hepatitis B is in a fulminant failure, take it that he's got hepatitis D co-infection. Now it is called Labria fever in the southern Brazil. Almost everybody, 90% of the population is infected with the delta antigen there. They carry delta antigen with them. So luckily, we don't have such a city in India, but it's pretty dangerous. Those people, poor fellows, we have D antigen positive. If they get on top of that D, they're dead. Now, therefore, we had to find out in our practices who's at high risk for hepatitis. This is important. So, who all do we check? Who do we all do the blood test for? Are the patients that come? Besides your own high suspicion that certain kind of people had to be checked, but asymptomatic screening of which person should be done. One is newborn of infected pregnant women, because perinatal infection causes chronic hepatitis, almost 90% of the people, children, and it is a lifelong problem with hepatitis B. So any pregnant woman who's positive for hepatitis B, the newborn should be checked. Similarly for hepatitis C. Similarly, household members and sexual partners of chronic hepatitis people, they should be checked. People living in poor sanitary condition, member A and E acquired orophycal route, and homosexual people and people who have multiple sexual partners. People who have had blood transfusions in the past, especially before 1992. At that time, we didn't check for hepatitis C in the blood. So people who got blood transfusion many years ago should be checked for hepatitis C. HIV patients. HIV patients have a co-infection of hepatitis B. Is quite common. Almost 1 to 7% people have it. People who have chronic hepatitis C should also be checked for hepatitis B, because co-infection is quite common. And if you treat them with hepatitis C with antivirals, their hepatitis B, if it's present in the hepatocyte, may reactivate. So you have to check for hepatitis B when treating for hepatitis C. Healthcare workers for our own protection, patients who are immunosuppressed, hemodialysis patients, because the hepatitis B and C are quite common because you're dealing with blood there. Tribal population in India, more than 11% are infected with hepatitis B, and close quarters where jail inmates are together and intravenous drug users can get both B and C. And since we screen them all, to what purpose? Because there's a purpose, and can we eradicate hepatitis? There's enough knowledge that we can eradicate hepatitis if we just became more alert, agile, and proactive. Because we know the diseases pretty well now. We know it's orophycal route for A and E. We know B is through blood and C is through blood. So if we take precautions, we can prevent these diseases completely, which means behavior modification among general population to tell them what B and C and A and E are all about. Good sanitation, clean drinking water, hand washing, the orophycal route, mind you, A and E. So if you wash your hands, it's not only coronavirus, but it also will help our B viruses. These viruses also have a lipid covering, if you saw. It's a lipid covering. So they're also amenable to detergents, just like in coronavirus. You can wash them away in 20 seconds washing. And then we should screen all the blood for transfusion. We should screen high-risk people at the list that I mentioned, even if they're asymptomatic. We have vaccination available for A and B. We don't have C vaccination. We should have vaccination for all these people for A and B. And if we find people with B and C, they should be treated. We definitely need R&D for vaccines and drugs. And unfortunately, B and C are, and for that matter, A, E, B and C are so rampant in India, but very little R&D is happening in the country. Most of these drugs and vaccines are, the research is done abroad, and it's kind of shameful for us as a country that we're not doing much R&D in these areas, though it's our disease, and it's more rampant in India than any other country. And then we need public health data collection and research and that to see where the sporadic episodes of E happen, so we can react to it quickly. So with that, I will end this lecture. I'm open to questions now. Thank you. Bharatji.
Thank you very much, sir. Uh, and I would like to take a questions from panel members if there are any. Panel members, if you have any questions, I request you to unmute yourself and ask the question.
Hello.
Yes, sir.
Yeah, can I ask one question? Shibanji, your presentation was excellent. The thing is that as being a chairman of Atrimed, you are dealing with Ayurveda. What is your take in this hepatitis? What is the possibility of coming out with an Ayurvedic drug in this?
We are working on antiviral drugs at the moment, and it's pretty exciting that we are working with coronavirus at the moment. And hopefully that if we succeed, in animal study, in vitro, in vivo studies, we have been successful. Phase 1 has been successful. Phase 2 study will start in Calicut Medical College in next few days. And if we succeed against corona, then we'll definitely work on antiviral drugs and see whether same or similar drugs from plant origin can cure or treat other viruses too. So exciting news is coming within the next few months from us.
Yeah, Bharat, can you share some data about what we are doing on hepatitis C?
Yes, sir, sure. And I'm very excited to inform our audience here that we have a world's largest plant molecule database, which holds small molecules, particularly plant secondary metabolite structure, which amounts to 4,08,000 molecules. And we have screened these molecules against two potential hepatitis drug targets, NS5A and NS5B. We have screened our plant molecules against these two hepatitis targets, and we have a potential targets to investigate in vitro. And I don't remember what exactly the plant name is, but we have a potential candidates to screen in vitro.
So mind you, these are nucleoside inhibitors. It so happens that there are various kinds of antivirals. If you remember the slide, you can attack the virus either at entry or at the endosomic level or in the nucleus or outside. It so happens that the nucleoside and the nucleotide inhibitors are the safest. They have the least side effects. So Bharat, what Bharat said is pretty exciting. If you're a nucleoside or nucleotide inhibitor, then hopefully we'll have less side effects. That happens.
And I want to add one more point. The selectivity towards these targets will be very high, as we'll be having a lot of divergence with human targets or human proteins when compared with viral targets, particularly this proteins involved in encapsulation as well as replication. So those proteins will be pretty much diverse when compared to the human targets. So selectivity can be achieved to the maximum extent. So this is what exactly has been achieved using the technique called as molecular docking studies. So through these studies, we were able to identify the potential drug targets, sir.
Good. Next question.
Yeah. Sir, yeah, I do have one more question. The thing is that you were talking about treatment for hepatitis C. What will be the cost involved with the antiviral treatment for vitamin C in India?
It's affordable at the moment for middle class people now, because I have a couple of patients who have been on sofosbuvir, and middle class people, they could afford it. I don't remember the exact cost, but it is few hundred rupees a month. Abroad is expensive. This is $1,000. It's about 70,000 rupees a tablet. But
And
because
and what is the duration of treatment?
on average 90 days, one tablet a day, 90 days, 90 tablets. So in the United States, USA, the treatment costs $90,000 and nobody can afford it. Even the government can't afford it, you go bankrupt. But in India, the prices are it's licensed out to one of the pharmaceutical companies who make it under license for the less rich countries, India and Africa and so on. It's a similar scheme that we did for HIVs. So the cost has come down in India. And of course, the poorest of the poor in India can't afford anything. So I'm talking the middle is affordable to middle class.
And what about hepatitis B?
Sorry?
The treatment
Treatment for hepatitis E.
The treatment for hepatitis B.
Sorry, I'm missing the last word. Hepatitis E, you said?
B.
Yeah, hepatitis
Yeah.
B. See, because hepatitis B, since we cannot cure them, so you have to select your patient properly. It's an incurable disease at the moment because your DNA replication machine is in the nucleus and is alive forever. So you have to select your patients properly, which is the patient has to be hepatitis B surface antigen positive, which means he's got chronic hepatitis. Then he has to be actively replicating the virus, which means he has to have hepatitis B DNA more than 2,000 or more. And hepatitis E antigen positive also will suggest the same thing. So if DNA and surface antigen are positive and DNA is high, you treat them. And you treat them with the drugs that I mentioned there, TAF, tenofovir, alfenamide. That's a drug of choice at the moment. I think it's pretty expensive at the moment because it's a new drug, but it's the best drug at the moment. If you treat them with old drugs, which is interferon, which can be done till tenofovir comes here. Interferon is not as expensive, but it has a lot of side effects. So hopefully, the government will let tenofovir TAF into the market, and we should be able to treat hepatitis B also.
Sir, is it available now in India?
I don't think so, but I got to be. I'm not sure. I haven't. I'm not in practice in here at the moment, so I don't know yet.
Sir, it is available. It's available.
Hepatitis.
Yeah, it's available in India.
Tenofovir is available.
Yeah, SOFU and the other one together. If you have Velpanat, that together is about around 400 rupees per tablet, and 28 tablets is 11,000 rupees.
No,
so what is it?
No, sorry, Ramji is talking tenofovir. Is it available? So Firstmovir is available. It's been available many years. But yeah. I'm talking tenofovir alpha.
It's available on 1mg.com. Yeah.
Okay, great. Okay.
Sir, how far is it effective?
Tenofovir, the rate is about 60-70% people become inactive.
Okay.
Not the best drug in the world. B is not that great, but it becomes inactive.
Well, sir, what is the possibility of finding a drug with plant molecules?
I don't know yet. The idea would be we had to succeed in, let's say, in CN coronavirus. Then we'll find out if we find a molecule in the air. The problem B is the biology of the virus itself. You have a virus which is like a chromosome, a mini chromosome inside the nucleus. And how do you attack it inside the nucleus? You can attack the offshoots of it. undeveloped proteins, etc., etc. But attack the DNA itself and destroy it will be pretty difficult task unless you destroy the DNA of the patient also. So the only way would be if we could attack it before it enters the nucleus. That means at the attachment stage, endosomal stage, or the late translation and replication stage in this virus cycle. But still, like I said, there's plenty of capsids in the nucleus. Once it gets in the nucleus, it's impossible to eradicate it. So to find those drugs, we're not there yet.
Sir, Dr. Damle, is there anything to comment on this? Any words?
No. I'm going back to tenofovir. Tenofovir. It is manufactured by 12 companies in India, including Cipla. I see here Zydus, Cadila, Dr. Reddy's, Mylan. So it's available.
Okay, great.
Yeah, price is between $4.99 is the cheapest I see. I don't know, $4.99 maybe just depends on how many tablets are there. Torrent Pharmaceuticals, and the highest I see is $2,500 by Abbott. So either way, it is definitely affordable for middle class.
So the good news is then you have treatment available both hepatitis C and B.
Yeah, yes, sir.
But not to treat C is to me is malpractice. Not to treat C, we should treat C completely and very vigorously because it's curable disease now.
Shivanji, the thing is that most of the times, many patients have come with a slight increase in ALT or AST. The thing is that most of the time it has been ignored. So the thing is that whether immediately we have to go for a hepatitis C test.
Yes. Anybody who's got mild elevation of AST, ALT, the first thing should come to your mind is, once you excluded everything else, is hepatitis C. You should do hepatitis C antibody. If it's negative, then you can worry about the other causes of AST, ALT elevation. You cannot escape not doing hepatitis C antibody in a person who's got mild AST, ALT elevation, because that's the only hope he has. He's asymptomatic, he's come to you, you're the doctor, so you got to check the antibody so you can offer him curative treatment.
Bharat, there is a question about drug-induced or abusive hepatitis versus hepatitis C. I think, can you just read it? Ketan has sent you.
Sure, sir. Sir, I have a question from audience. It goes like this. Is it possible to differentiate fibrosis caused by hepatitis A, B, and C, alcohol, or drug abuse using histopathology technique?
Hepatitis A does not cause fibrosis. B and C causes fibrosis, and you just do a blood test, you differentiate. You don't have to differentiate by fibrosis. Blood test will tell you if the B surface antigen is positive, it's got B. If C antibody is positive, it's got C. So to do a liver biopsy to diagnose B and C is not needed.
Basically, he's telling that you correlate with the blood test.
Just do the blood test. It's a simpler way to do it.
Just do the blood test.
And to answer your question directly, you cannot differentiate between B and C in histology.
Thank you, sir. I think the question is well answered. And you were talking about hepatitis infection in tribals. Are many tribals are affected more, or only Australian tribes were affected? And
No,
what was the reason?
I was talking tribals in India. Australian tribals was the story value that Australian antigen was found there. I'm talking tribals here in India. It varies from 4 to 11%. In Madhya Pradesh, the tribals have 11% infectivity rate. So, 1 in 10 people have hepatitis B. So, which means A, they're going to suffer themselves, B, they're going to infect others. So all it needs is a little more care from us, and because these diseases are preventable.
Okay. Thank you, sir. Thanks for the answer. And I have a next question from the audience. Um, is the effect of ascites is there on liver?
Ascites is a sign of portal hypertension.
Mhm.
That means, in this context, ascites is fluid accumulation in the peritoneal cavity. Um, the fluid comes out by leakage from the liver surface. Once the fibrosis, which is cirrhosis, happens, that increases sinusoidal or the intrahepatic portal pressure, because under the fibrosis these veins become stiff. So the portal pressure increases and the liver starts leaking fluid, which accumulates in the peritoneal cavity, causing ascites. So ascites is a sign of cirrhosis, and it's also got a prognostic angle. The person with cirrhosis who has developed ascites, that 50% mortality in 5 years. It's almost like cancer. If you see a person with cirrhosis ascites, so we better be overactive to treat him, because he will 50% of them will die within 5 years.
Okay. Thank you, sir. And I have a next question from Dr. Amruta in the audience. Question goes like this: if a patient is tested hepatitis B antigen positive with normal LFTs, USG findings, what interval he or she should consult and do investigations, and what all investigations he or she should undergo?
If you have a person with hepatitis B surface antigen positive,
Yeah.
and the patient had hepatitis more than 6 months ago, so by definition, he's already got chronic hepatitis. Now we have to evaluate him and see, is the hepatitis virus active in the nucleus? And number two, how much damage has happened to the liver in terms of fibrosis? So the tests that are needed right away are hepatitis B DNA level, which will tell you the activity, and hepatitis E antigen, that will tell you the activity in the liver. If DNA is more than 2,000, then this person needs treatment. Now, to evaluate for fibrosis, I already said those FibroSure, FibroScore, and APRI AST platelet ratio, and at least the minimum is an ultrasound to see the liver fibrosis. That'll tell you whether the person just has chronic hepatitis or is progressing towards cirrhosis. Then they should be followed, they should be treated, but in any case, the follow-up should be done every 6 months. Anybody with chronic hepatitis C or B, an ultrasound of the liver should be done every 6 months to detect early cancer, because early cancer is can be cured by lobectomy or liver transplant. If you miss it, then you can't cure it. So everybody with cirrhosis due to B and C should get an ultrasound every 6 months.
Thank you, sir. And I have a next question. It goes like this. Should we need to regularly check hepatitis B inactive patients for viral DNA load? And if so, what is the interval?
Now, the hepatitis, if your first test shows hepatitis B surface antigen is positive and AST, ALT are normal, then you can check his DNA in 6 months to 1 year. But if AST, ALT are high, which are indication of activity, you should check the DNA right away. So it's a combination of AST, ALT, and surface antigen. If all three of them show positive, AST, ALT are elevated, and B, surface antigen positive, check DNA level right away and decide to treat. Most probably DNA will be high, and the patient will end up in treatment. People who are inactive.
Yes, sir. Sir, that was my question. Yeah, if the AST and ALT levels are high, we need to check them right away, I understand. But after being treated, if they go into the state of inactivity, that is a viral load going below 2000, after that, at what intervals should we keep observing them?
6 months. Every 6
Every
months.
6 months, we have to do the Hep DNA.
Yes.
Thanks.
No, do DNA, do AST, ALT every 6 months, and you suspect, then do a DNA.
Okay, yeah, thanks.
Sir, I do have one more question. The thing is that what is the criteria of selecting whether lobectomy or liver transplant is required?
All right, it's called. All right, this is people have tried to define hepatocellular carcinoma called HCC. And there's a classification which is accepted the world over. It's called Barcelona Clinic classification. Barcelona Clinic classification, BCC1. If you remember, we used to classify cirrhosis as child spew classification 1, 2, 3, 4. One is perfectly, person with cirrhosis who can go around with normal activities and liver function is normal, and 4 is who has massive cirrhosis and varices and so on and so forth. Now, Barcelona classification, the BCC, Barcelona Clinic classification, is for HCC, hepatocellular carcinoma. If you have one lesion less than 5 centimeter, only single lesion less than 5 centimeter, they deserve curative resection. If it is more than 5 centimeter, then you have options. That is transarterial embolization called TACE treatment. If it is more than one lesion or multiple lesions, then you go chemotherapy. So to answer your question directly, is 5 centimeters or less of a lesion and a single lesion seen on MRI needs lobectomy.
Thank you.
Yeah, thank you, sir. And I have a next question. Does hepatitis B or C infection gives protection from another disease?
Well, hepatitis B infection gives protection for hepatitis B, nothing else. No other disease. And we said it doesn't protect you from any other disease. And now I would just want to go a couple of things here, though. Just these are kind of caveats, pearls. One, the alcohol and hepatitis B and C don't go together. People who drink alcohol, even mild amount of alcohol in the presence of hepatitis B and C, get cirrhosis faster and their inflammation aggravates. So no alcohol for B and C. Number two, in acute hepatitis B, AST, ALT is something like 1,000 to 2,000 or maybe more. There are very few conditions. There are just 2 or 3 conditions that give you as high a level of AST, ALT. One is hepatitis B, and second is shock liver. You have a sudden sort of hypotension, then the AST, ALT goes sky high. So if a patient that comes to your office, AST, ALT is 1,000 or 2,000, is hepatitis B unless proven otherwise. Hepatitis C, if patient comes as an outpatient, liver enzymes are about twice the normal or less. If it is 200 or more, then it's probably active hepatitis C, which is very rare. Most of them have around 50, 60 AST and ALT. So you can diagnose these things just in the office blood test, just by looking at the liver profile.
Yeah, thank you, sir. And I have an question from the audience. How far the liver cells can regenerate with diet if there is a fatty liver?
All right. Now, fatty liver means fat accumulated in the liver. It's also called, now the technical term is NASH, non-alcoholic steatohepatitis. Alcohol causes fatty liver, so they named this a non-alcoholic steatohepatitis, also called NASH. And now NASH also happens in people who are overweight with the BMI of more than 30 or so. So in that diet, weight reduction by 10% or more will reverse the fatty liver, reverse the NASH, because NASH itself can lead to cirrhosis, it can lead to inflammation, AST, ALT elevation, and cirrhosis of the liver. In Western countries, NASH is becoming the commonest cause of cirrhosis because they've been able to control hepatitis B and C. And the commonest cause for cirrhosis would be NASH because of obesity, metabolic syndrome, and non-alcoholic steatohepatitis. So a diet helps. If you reduce, if you lose weight, then NASH may disappear. We don't have a drug for this. Vitamin E is tried, and some anti-diabetic drugs are tried, but nothing has worked. At the moment, the best thing is weight reduction by 10% or more of the body weight.
Yeah, thank you, sir. And sir, do you think we need a protocol at national level on how to follow up with hepatitis B, C, E, and D?
We don't need it's not a national thing. It's on Google. It's a common knowledge now. It's got nothing to do with the national level protocol. It's a common sense that B has to be chronic hepatitis B, just as I mentioned earlier. I will just summarize it. Do a surface antigen. If it's positive, check AST, ALT. If it is high, then do a DNA. If the DNA is high, treat. In hepatitis C, do hepatitis AST, ALT. If it's mildly elevated, do hepatitis C antibody. If hepatitis C antibody is positive, do quantitative hepatitis C antigen. They'll tell you it is elevated more than 6 million units, and then treat. So there is no particular protocol needed. It's simple. It's just simple. You can decide in the lab just by these simple tests to treat or not to treat. And then follow up every 6 months or so to make sure they don't develop liver cancer or cirrhosis.
Okay, thank you, sir. And in your opinion, what may be the impact of COVID-19 in hepatitis B or C patients in particular?
We don't know. COVID is a new disease, only 7 months old. So we don't know at the moment.
Thank you, sir. And if there are any more questions from panel members, I request you to ask.
As you told that in the mild in hepatitis C, there should be a mild elevation of AST and ALT. So, what does it mean that mild means? Is there is a marker or a range in which we have to be more careful that if the AST ALT level is more than this level, then you have to check for hepatitis C, or for any elevation we have to do it?
Any elevation, hepatitis C, because it's quite common a disease and it's curable and treatable. So hepatitis C patient will never come to you with, AST, ALT upper limit is 40. So you see a typical hepatitis C patient with a level of 50, 60, 70 or so, rarely more than twice. You hardly see AST and ALT more than 80 or 100 in these patients. So suspicion should arise the moment anybody comes with AST elevated, which is borderline high. Unless you only have a cause for that, you should check it out. You cannot wait for very, 10 times elevation of AST, ALT, check for hepatitis C. No, it won't happen.
So what if the patient is having this one fatty liver? So whether it may cause a slight elevation, so it may be correlated with this, or
no? But then you have to prove it. Patient, like I said, the real term now is NASH, not the fatty liver, and non-alcoholic steatohepatitis. The reason being is this: if a fatty liver is causing inflammation, the AST ALT goes up. Now, fatty liver by itself will not cause AST ALT elevation. That's why it's called steatohepatitis now, because there's a patient with fat in the liver, which causes inflammation. And so you had to prove it that it's steatohepatitis, which means this person will have hepatitis C antibody negative. Ultrasound will show fat in the liver. So you got a diagnosis of NASH in this patient. And the treatment is weight loss. If you want to treat the pioglitazone is the anti-diabetic they've tried. They've tried, may or may not work, but these are the two things. So you had to prove it has got steatohepatitis or hepatitis C. Because steatohepatitis itself is dangerous. They can become cirrhosis. So it's a serious disease.
Yeah, sir, there is one question from audience. Being allopathic expert, what has really motivated you to work on plant-based molecules or Ayurvedic research and establish a plant-based company like Atrimed?
Dr. Damleji, would you want to answer that if he's there?
Sir, you answer, then I will tell.
Well, in our idea, our idea is either you are practicing science or you are not practicing science. So to us, it isn't that I'm an allopath, therefore I'm averse to plants. Plants have been a source of great molecules before that are given to us. You already know the commonest being digoxin that comes from plants. So we have had plant molecules that have been extremely wonderful. And secondly, as a matter of pride, being an Indian, that this is our tradition. We used to treat from 2,000 years ago based plant concoctions to give to our patients because we didn't have the scientific tools at that time to analyze it. But somehow or the other, we lost the pride in ourselves and lost the ability to analyze it. And this 2,000 years of inertia has brought us to where we are now. So we want to, as Atrimed, we want to rejuvenate the whole thing one more time. That if Charak were alive, he'd be proud of us. That we want to can capture his wisdom and see what modern scientific tools prove or disprove whatever he said. And most of it is true. Just the way we've seen antiviral drugs coming out of this and other drugs that be coming out is to me, the world is not divided into plants and animals and humans and so on. At the end of it, my DNA is identical to a DNA of a tomato or a potato. DNA is no different. It's just that in evolution we've taken different paths, and I am here where I am, and plants are where they are. And we have evolved together, and we are still living together. It's not that we are away from each other. We are still living together. We have more, bacteria in our bodies than we have our own cells. So the idea is be scientific about it, have honest, scientific vigor to analyze and accept the truth wherever it falls. And if it be from the plants, so be it. As a company, we had to decide where to go. And our bunch of people that we work with at Atrimed, we are proud people. So we are digging up the Indian tradition and say, can we create some really good molecules from the ancient wisdom that will be curative for all? That was the purpose of getting into this.
Yeah, it'll be interesting. I have around 2-3 points to make. Before that, I want Anju. Anju, are you there?
Yes, I'm here.
Yeah, Anju is someone who was in Netherlands before she came here, and she was in a university working there, and she came and joined us. And if we really look at the way we do science, I want her to really say, tell us honestly that are we doing real science? Do we have any prejudice, or do we report what we see as it is and how the blinding is done, etc. Can you just say, Anju?
Yeah, I think we do research, at least whatever is done at Atrimed Biotech. We are doing research exactly like how it is done in, well, not exactly like how it is done in academic research, because academic research is not as focused as we are. And it is also not as time bound as our projects are. But the scientific vigor behind it is exactly the same as it is in academia. In fact, most of us are from an academic background, like me and Bharat and so on. So I think we bring in the same scientific vigor and discipline, and our approach is exactly the same. I didn't do different research when I was at a university than I do now. My approach is the same. It's just that research here is more focused, and it is very true that we are all quite impartial, because we are all our research is quite double-blinded all the time, and each of us is privy only to some information which the other person doesn't know, and this keeps us quite in check, and there is absolutely no way we can fudge our results or try to make things look better than they are, or worse, or whatever. So there is no scope for prejudice in the setup, the research setup, the way it is at Atrimed. And we certainly report only what we actually observe.
Yeah, thank you, Anju. Yeah, Manoj and Bharat. Coming back to the question is, see, this is the first session we had with the clinician. All this time we used to have non-clinicians talking about it. I'm not telling that's not right. This is right. I'm just telling the difference. Clinicians have their own way of practical application of science, whereas pre-clinicians have their own method of how to develop things. So today we had a lecture from Dr. Shiban, and I think we should have more and more from clinicians who just say that according to today's protocol, this is what has to be done. And I see two problems here. One is quantity of patients for a person to test. Second is the mindset of clean mindset of telling better or not. So statistical significance is very important. So I think if we follow this path, even with Ayurvedic drugs, we may be able to find or may not be able to find. For hepatitis C, we have seen, Bharat has given us a list of, plants which can work exactly like the way the, current allopathic drugs work. But then to take that to the level of marketing is a long term, and that's what Atrimed is all about. We want to do that way, and that the following that way is difficult, but then it gives us confidence. Every time I do in vitro works with in silico works with in vitro accepts in vivo, and in vivo accepts uh, clinical trial. There's much more confidence in us, and I know there's a reason for that, and that's how we have to develop drug development, and at Atrimed we are doing that. For example, today's unlike earlier works in hepatitis about hepatitis, Dr. Shivan is very clear. Now, what he says is because of volume of work done by several people on hepatitis A, B, C, D, or E, whatever, those are irrelevant. Now, we should understand hepatitis A and hepatitis B are not the same viruses. A is a naked virus. B is not. When you compare B and C, B is a DNA virus, C is an RNA virus. So just because they have similar names does not mean that they are similar. So we should understand each virus has its own approach, and based on the approach there will be difference in the the way they infect, and there will be difference in the way we have to counter them. So in Ayurveda, do we have methods? We don't know, but is there a way we can explore these methods? Yes, Bharat has an answer for that. In silico we can start, and then we can go ahead with the in vitro and in vivo, etc. But being ourselves, asking ourselves, am I doing the right thing? When I say, am I doing the right thing? When I say that drug A kills, hepatitis C virus, am I telling the truth, or could there be a fallacy in my statement? Is exactly is what is science about. So that's the attitude. I mean, it's not like a lawyer. Lawyer is supposed to defend his convict, or whoever is his client. So that is the attitude that we have to build, develop. And today's talk is all about understanding precisely what we need to do if we have to save the patient. Not about it's not vague. It's precise. If you have this virus infecting your liver at this stage, and these are the biochemical changes, these are the sonological changes, this is what you have to do. So I think we have to reach that stage for every herbal prescription we give. Otherwise we will not reach nowhere. That's what I think. Over to you, Bharat.
Yeah, thank you, sir. I request Dr. Manoj Kalor to deliver the vote of thanks.
Thank you, Bharat. And we had an excellent presentation from Chibanji. Thing is that I know him for a long period of time, and it is unfortunate that it's the first time I'm hearing his lecture, his class, and it was a miss for a long time. And your presentation was excellent, and it has given a excellent insight about the hepatitis A, B, C, and E. And most of the times, as I've asked you many the previous. And the thing is that most of the times when a patient comes with a slight elevation and AST or LT, we usually think that maybe because of some reason that it will come down. So usually we may not go for hepatitis C test also. And this has given an insight to really look into it. And thank you, Shibanji, for your excellent presentation. Thank you. And thank Dr. Damle, Dr. Ladad, and Dr. Ajit for being present here, and Dr. Bharat for his Bharat and Anshu, and all those who are part of this and who are listening program. Thank you, and we'll be coming up with the next series. Thank you, one and all, and good night. Thank you.
Thank you, sir. And it was good. Yes, sir. Hello.
Bharat, I just said thank you very much for arranging this.
Yeah. Thank you, sir. And I believe it was really a great session, and we assure that we are coming out with many more sessions like this in our coming future. Thank you, everyone, for your great participation. Thanks a lot. Good evening. Thank you, Shubhan, sir. Sir, with your permission, we will conclude the session.